All right. Good morning, everyone, and welcome to our St. Joseph Healthcare Hamilton Medical Grand Rounds this morning, October 27th, 2022. Next slide, please. And we're delighted to have you all joining us on this lovely fall day. Next slide. And as always, we will start off with a land acknowledgement. We acknowledge that St. Joseph Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee Nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. Next slide. So it's my great pleasure to welcome today Dr. Meera Joseph, who newly joined us as a GFT faculty and working at St. Joe's effective July 1st. Although she's been at MAC for a while now, as we'll hear in a bit more formal introduction. She's going to be speaking to us today on the topic of the age of subspecialty geriatric medicine, the introduction of geriatric nephrology at McMaster University. And I'm going to hand things over to Dr. Anna Matthew, who is our head of service for nephrology, fairly newly herself, started September 1st and has been doing a fantastic job. Over to you, Anna.
Thank you, Madeline. So it's truly my pleasure to introduce one of our newest full-time nephrology division members, Dr. Meera Joseph. Dr. Joseph attended Western University and she earned both a Bachelor's of Engineering Science and a Bachelor's of Science. And then she followed that up with an MD in internal medicine residency at Western. Then she completed her nephrology fellowship right here at McMaster and was the first graduate from McMaster's Geriatric Nephrology Fellowship Program. And she's currently pursuing a Master's of Medical Education. Dr. Joseph's clinical interests include improving a palliative approach and preventing geriatric syndromes in patients living with end-stage kidney disease. With a colleague, Dr. Meera Sidhu from the Division of Geriatric Medicine, she is co-program director of the Geriatric Nephrology Fellowship Program, and she's leading the first collaborative geriatric nephrology clinic in all of Canada, which is right here at St. Joe's. And she provides faster access to geriatric care for patients with renal disease, and I've much appreciated her help. I've referred several patients to her already. So without further ado, please take it away, Dr. Joseph.
Thank you so much for that very kind introduction, Dr. Matthew and Dr. Verhofstadt. It's such a pleasure to be here today. I wanted to present on something that I'm passionate about, but also a topic that's relevant to all of you who are here today. So I'd like to explore the growing challenge of providing specialty care to an aging population, journey through the introduction and implementation of geriatric nephrology at McMaster, and explore strategies to equip our learners with the skill set needed to provide specialty care to an aging population. I have no conflicts of interest to disclose today. So I thought about starting with a patient case from our geriatric nephrology clinic, but instead I thought I would step back from my role as a physician for a moment and share my experience as a family member and a caregiver. So these are my own grandparents, and I'm sharing their story with their permission. So on the left are photos of my grandma and grandpa living in Jaffna, Sri Lanka in 1982. And on the right, it's them living in London, Ontario in 2022. So my grandpa was born in 1929, making him 93 years old today. And my grandma was born in 1935, making her 87 years of age. When my grandpa was born in 1929, the average life expectancy in Canada was only 58 years. I tried to find the life expectancy in Sri Lanka at the time, but I couldn't find it. But 20 years later in 1950, it was also 58 years. So I imagine it was much less 20 years earlier when he was born. The infant mortality rate in Canada at that time was 125 deaths for every 1,000 live births. So my grandpa was one of 8 children, only 3 of whom made it to adulthood. And he actually lost his first wife in her 20s as well from sepsis. So the fact that he's living here into his 90s with my grandmother is quite remarkable. So they married in 1961 and had eight children together. And then in 1983, they moved to Canada. And really from 1983 to 2013, they led a fairly healthy life with a great quality of life. So they both had hypothyroidism, they had cataract surgeries, and they had osteoarthritis. And for this, they were mostly followed by their family doctor with ophthalmology for their cataract surgeries and orthopedic surgery to do a knee replacement for my grandma. But then they hit their 80s, and quite quickly, their problem list just exploded to include hypertension, diabetes, interstitial lung disease, coronary artery disease, atrial fibrillation, congestive heart failure, a GI adenocarcinoma, bladder prolapse, BPH, recurrent UTIs and sepsis, osteoarthritis, cognitive impairment, depression, CKD, and acute kidney injury. And with this increase in the number of medical issues, the number of specialists caring for them also increased to include GIM, respirology, cardiology, med-onc, general surgery, urology, gynecology, geriatric medicine, and now palliative care. And I'm sure that many of you have experienced this in either your own family members or your patients. However, it wasn't just their problem list and appointment list that changed. They also started to develop geriatric syndromes such as falls, cognitive impairment, frailty, gait disorders, and depression. And these geriatric syndromes, on top of a growing list of medical issues, had a significant impact on their function and their quality of life. In addition, their life space mobility, which was their ability to safely move within and across environments that expand outwards from their home to their wider community, decreased. So up until his late 70s, my grandfather was actually making international trips. As the years progressed, his life space mobility had decreased from out of town to within town, to his own backyard, to his own house, and now mainly his own bedroom. And the children that they had in the 1960s and 70s, who were once cared for by my grandparents, have now become their caregivers, providing 24/7 care. So as Canadians working in healthcare, we're going to be seeing an increasing number of patients like my grandparents. In 2021, the Canadian population had 871,400 people aged 85 and over, more than 6 times as many 50 years earlier in 1971, where that population was only at 139,000. And by 2050, the 85 plus Canadian population could reach more than 2.7 million people. So this, as you can imagine, will have many implications in terms of health and home care services, housing, transportation, and consumption habits. So this rapid change in population demographics has already changed the landscape of nephrology for the last few decades. So what this figure shows is the large number of incident end-stage kidney disease patients over the age of 65 and 75. And what's not shown in this figure is that their survival on dialysis is increasing as well. And what makes it challenging to navigate this change in demographics is the increased prevalence of all of these geriatric syndromes that I showed earlier. The presence of these syndromes makes the care that we provide much less straightforward. So I just want to go through some of these geriatric syndromes that we see in chronic kidney disease and end-stage kidney disease. So cognitive impairment in CKD and end-stage kidney disease is common. So the prevalence of dementia in those aged 65 and older without end-stage kidney disease is about 10%. And for those who are 85 and older without end-stage kidney disease, it's about 35 to 40%. The prevalence of cognitive impairment in end-stage kidney disease is 30 to 60%. The figure that I'm showing on the left is from a study looking at the prevalence of cognitive impairment in dialysis patients compared to controls. And what they found was that in all groups, the prevalence of moderate and severe cognitive impairment was higher in dialysis patients compared to the controls. And what's really interesting is that it's not just an age-related problem in our patient population. So what I've highlighted in that red box there is that in the age 55 to 64 group, 32% of the control group had moderate or severe cognitive impairment compared to 75% in the dialysis cohort. And CKD comes with many risk factors for developing cognitive impairment, which include the traditional risk factors such as hypertension and diabetes, but also dialysis-related factors such as hypotensive episodes and fluid shifts on dialysis. So it's been shown that during dialysis, cerebral stunning occurs where the blood flow to all parts of the brain decreases, and that decrease in blood flow is actually sustained for a period after dialysis. And that's what that figure on the right shows. So what they did in this study was they started to measure blood flow to the brain 15 minutes before dialysis, all the way to 30 minutes after dialysis. And as you can see, even after dialysis is stopped, there continues to be a decrease in blood flow. There are many implications of cognitive impairment. Our patients with impairment on cognition sometimes have decreased adherence to treatments. They're at increased risk of secondary iatrogenic hospitalizations and death. They have decreased quality of life, and this can ultimately preclude patients from receiving a transplant. So falls are a significant concern for our patients with chronic kidney disease. I know that here at St. Joe's, the nephrology ward has one of the highest falls rates in the hospital. So falls in the community dwelling dialysis patients is actually similar to that of people living in nursing homes. And there are many dialysis associated risk factors for falls, such as hypotension and cramping on dialysis. And because CKD also impacts bone health, our patients are more susceptible to sustaining a fracture from their fall, which leads to increased mortality. The images on the top are from a patient of ours a couple of years ago who had a fall leaving the dialysis unit. He had this intracranial bleed and unfortunately passed away a few days later. So it can have significant consequences. Malnutrition and weight loss are not uncommon. So chronic kidney disease and end-stage kidney disease increase patients' risk of anorexia. And this could be due to uremic toxins, nutritional losses during dialysis, depression, and their highly restricted diet, where we're trying to restrict potassium and phosphate and make sure they're on a diabetic diet. Physical frailty is also significant in chronic kidney disease and end-stage kidney disease. So this was a study of 2,775 patients who were enrolled in the dialysis morbidity and mortality study, and they were evaluated for frailty using a questionnaire. And in the study, 2/3 of the study population met the study definition for frailty, including 44% of those aged younger than 40 and 40 to 50% of those aged 40 to 50. And frail patients are more likely to be hospitalized for any reason or die. And finally, drug therapy in the elderly is challenging when patients are on so many medications. The graph on the top is from a study that looked at the number of daily medications that are being prescribed to dialysis patients. And as you can see, many patients were on more than 10 medications per day. Drug therapy is challenging in any elderly patient, but there is a 3 to 10 times increase in the incidence of adverse events due to medications in elderly patients with chronic kidney disease in comparison to those without chronic kidney disease. So I hope that what I've shown is that a one-size-fits-all approach really doesn't work, and how we have to approach our 50-year-old must be different from how we approach some of our older patients. And lifespan does not necessarily equal health span. So the longer a patient lives, the more frailty, disability, and functional decline they experience, and that has to be reflected in our care plans. However, it's not just as nephrologists who need to develop additional skills to manage the implications of this coming of age. This holds true for all subspecialties and disciplines, as I've shown in this survey of articles here on this slide. So for example, the authors in this article wrote, mainstream cardiology has become de facto geriatric cardiology, but it still lacks a systematic approach that incorporates age-related complexities into clinical decision-making. Skills are needed to assess patient preferences, circumvent the hazards of hospitalization, facilitate successful transitions from one care setting to the other, engage in useful risk-benefit discussions, provide care collaboratively within a care team responsive to the needs of the oldest patients, and incorporate geriatric medicine into routine clinical practice. So this was another article that tried to define what the key elements are to provide optimal care to the older adults with cardiovascular disease. And what they say is that you need to consider the medical needs, mind and emotion, the social environment, and physical function. But at the same time, you're also paying attention to the 4 M's, so medication, mentation, and mobility, to determine what matters most. So there is an evident need and a clear call for subspecialty geriatric programs. So next, I'd like to walk you through this coming of age in nephrology as we journey through the implementation of geriatric nephrology here at McMaster. So just a little bit about how geriatric nephrology came to be. So in May of 1985, they held the first international symposium on geriatric nephrology. They had 6 meetings and even developed their own journal of geriatric nephrology. But despite all of these efforts, the interest among nephrologists didn't increase. The membership to the society was very small. And because of a lack of article submissions, they were unable to sustain the journal. But recently, there's been renewed interest in the area. And this is because of that increase in the incidence of new patients with end-stage kidney disease over the age of 65, who, like I said, are the fastest growing group of patients requiring dialysis. And because of this, nephrologists are being forced to practice as amateur geriatricians. And also the automatic reporting of eGFR using the MDRD formula has led to a large number of elderly patients with low GFR, resulting in many referrals to nephrology. So a couple of weeks ago, I was actually referred a 100-year-old patient to my general nephrology clinic. And this was the first time she was seeing a nephrologist. So that was at the age of 100. So I'd like to start off by talking about our geriatric nephrology clinic. But before I do that, I just wanted to talk about the landscape of geriatric nephrology clinics in North America. So before we started our clinic, the only other geriatric nephrology clinic was at UHN in Toronto. And this was not a collaborative clinic. So it was run, or it is run by Dr. Meera Joseph, who's an incredible nephrologist, who's also certified in geriatrics. And she sees geriatric nephrology consults for her colleagues. When I was working with her, they did not have any allied health in the clinic, but that may have changed now that we're maybe getting out of COVID. The other clinics in North America are one at Mount Sinai in New York. So they have a geriatric nephrology clinic, which I couldn't find much information about to see how they run, but they also have a kidney supportive care clinic, which is like a palliative care clinic. And then I'll talk a little bit about the geriatric nephrology clinics at Veterans Health Administration. So this was a study that looked at 2 innovative programs implemented at the Veterans Health Administration to incorporate geriatric assessment into a nephrology visit. So the first clinic that they implemented was called CGA for CKD. And this was a partnership between geriatric medicine and nephrology to improve the recognition of geriatric conditions and support person-centered treatment plans for individuals with CKD. In this clinic, the geriatrician was embedded into the kidney clinic, and the geriatrician then discussed abnormal findings in people with the nephrologist, and then developed plans for further evaluation and co-management. The second program they implemented was the Renal Silver program, and this was originally developed from a renal palliative care clinic for individuals with advanced kidney disease. This was run by a nephrologist who had received additional training in geriatrics, and the findings informed the CKD treatment plan, including dialysis decision-making discussions, and also triggered specific care processes and discussions with local geriatricians to manage abnormal findings. So what they found in the study was that at least 25% of veterans had functional limitations that the geriatric assessment identified. Cognitive impairment and difficulty with IEDLs was commonly identified and addressed through further evaluation in their specialty referrals. And the providers considered these problems in the development of an individualized treatment plan. There were 3 themes that emerged from the qualitative analysis regarding the role of geriatric assessment in individuals with CKD. The first was that geriatric assessment allows providers to anticipate risks and prioritize individuals' concerns. The second was that geriatric assessment helps individuals and their caregivers recognize and discuss preference-sensitive treatment decisions. And finally, geriatric assessment helps providers identify resilient older adults experiencing healthy aging. So here at St. Joe's, the Geriatric Nephrology Clinic was initially a pilot project with Dr. Sidhu and our multi-care kidney clinic team. It was a once monthly clinic at St. Joe's, Charlton, where Dr. Sidhu embedded herself into our kidney care clinic. So this is similar to the CGA for CKD program at Veterans Health. However, there was no subsequent funding to consider this clinic, so it kind of died off. And then I expressed interest in pursuing a geriatric nephrology fellowship. And with that, there was renewed interest to develop a structured geriatric nephrology program. And for this, funding was received from the Ontario Renal Network for our outpatient clinic. So this is truly a collaborative effort between geriatrics and nephrology. So Dr. Sidhu and I are present in each clinic. We have clinical clerks or clinic clerks from peritoneal dialysis who provide our administrative support. We have a nurse from the geriatric medicine program with training to do cognitive testing. And the clinic space that we use is the geriatric and peritoneal dialysis clinic space at the King campus location. So we were able to build a referral to our clinic within Dovetail. Our inclusion criteria are community dwelling patients over the age of 65. However, we have seen patients from long-term care as well, patients with one or more geriatric syndromes that have not been previously addressed, patients with multiple comorbid conditions, patients who are currently attending CKD clinics with a plan to transition into MCKC clinic. We also include patients who are currently receiving dialysis treatments. So unlike the typical nephrology consult, which is about 30 minutes in length, this consult takes about 2.5 hours to do. So initially, the patient, the caregiver, and our nurse Tracy meet. They go over the patient's medications, and Tracy gets the patient's vitals. Then Tracy takes the patient and performs cognitive testing, which will include the MMSE, the MOCA, the Geriatric Depression Scale, plus or minus the TRAILS A and B, RUDAS, and the Geriatric Anxiety Scale, depending on their needs. And while Tracy is doing that, I will take the caregivers into a different room, or Dr. Sidhu will take the caregivers into a different room. And what we'll do is gather collateral history. Next, the physician seeing the case will take the patient and perform a physical exam and obtain history from the patient. And then what's unique about this clinic is that we then have a conference with all the learners who are present. Sometimes Tracy joins, and both Dr. Sidhu and I will be present as well. And we talk about the case and come up with an assessment and a plan moving forward. And then we meet with the caregiver and the patient and discuss the plan along with next steps. So this is just a clinic snapshot from August of 2021, when we first started this clinic, to October of 2022. In this time, with 1 to 2 clinics per month, we've seen 34 new consults. So in each clinic, we can only really see 2 new consults and then follow-ups in the afternoon. We've seen patients with chronic kidney disease, patients who've received a transplant, as well as patients on dialysis. The reasons for referral have largely been for cognitive impairment. So this has made up over 50% of our referrals. However, we've also received referrals for falls, frailty, psychiatric assessment, driving assessment, and capacity assessments. The primary diagnosis that we've given is reflective of the reason for referral. So it's usually some kind of cognitive assessment. So either mild cognitive impairment, mixed dementia, Alzheimer's dementia, or vascular dementia. But we've also given diagnoses of frailty, depression, and psychiatric disorders, among other things. And because this is a comprehensive geriatric assessment, we don't limit our assessment to what the patient was referred for. So we really do a head-to-toe assessment and try to address as many issues as we can. So we talk about home supports and arrange for them if needed. We address polypharmacy. We do driving assessments. We address goals of care and advanced care planning. We manage depression and anxiety. We try and manage pain and symptoms. And what's unique about this collaborative clinic is that we also have discussions about modality decision-making. So patients who are undecided between, say, conservative renal care and dialysis, or sometimes we've even referred or been referred patients for pre-transplant assessments to see if they would be suitable for a transplant. And finally, we've even had a couple of conversations about dialysis discontinuation. So I just want to present a case of an 80-year-old female with end-stage kidney disease who was referred to our clinic for cognitive and capacity assessment. Her past medical history was significant for acute kidney injury in 2014 with ischemic bowel disease at the same time. She also had a hip fracture, hypertension, chronic atrial fibrillation on warfarin, osteoarthritis, and osteoporosis. She was on 10 medications total. Most of them were for her CKD or hypertension, but the medications of interest to us were Tylenol 3, 1 tablet TID PRN, warfarin, and zopiclone at 3.75 milligrams at night. The patient wasn't aware of why she was referred to our clinic. She denied memory concerns, stating that any changes were normal aging. She denied short-term memory loss, forgetting conversations, and repeating questions. Even though this was during the heart of the pandemic, she couldn't remember that we were in the middle of a pandemic and couldn't even name the COVID-19 virus. Even though they had a housekeeper and her husband did most of the work around the house, she thought that she did all of the laundry, that she did the cooking, the cleaning, and didn't remember that they had a housekeeper. And she thought that our Prime Minister was Pierre Trudeau. Her husband first observed cognitive changes approximately 18 months ago, where she would forget conversations and repeat questions, misplace objects, and have geographic disorientation. She often wouldn't remember why she was wearing a mask or why the stores were closed. And her husband stated that her functional decline really started after her admission for ischemic bowel. With regards to her BADLs, she was fairly independent and even was independent with her ostomy care. But when it came to her IADLs, her husband did the shopping, the housekeeping, managed the finances, took her around to different appointments and places. And although she assisted with some simple meals, he did much of the food preparation as well. So when she was referred to us, her creatinine was 592 and her eGFR was already down to 5. Her urea was 26. Her potassium was above normal at 5.7. She was acidotic with a bicarbonate of 15. Her hemoglobin was 93. So she was anemic, and she also had some evidence of iron deficiency. Their plan when we saw her was to try and delay dialysis for as much as possible. But if she needed dialysis, then she would accept it. We did cognitive testing on her, and she scored 13 out of 30 on the MMSE, 3 out of 3 for recall, but she was not oriented to place or time. She scored 6 out of 30 on the MOCA with 0 out of 5 for recall. And we asked her to draw a clock, place all the numbers on the clock, and place the hands at 10 past 11. And this is a test for our visual spatial abilities, but also for attention and executive function. And what you see below there is the clock that she drew for us. We did do a geriatric depression scale, and she scored 1 out of 15, showing that she probably was not depressed. So there are many issues that we had to consider in this patient. So the first was her cognition. And what we had to ask ourselves was, if we remove the renal failure, so say we started her on dialysis and we were able to stop the Tylenol 3 and the zopiclone use, would her cognitive function improve significantly? And what we felt was that the answer was no, and that this was likely a presentation of mixed Alzheimer's and vascular dementia. And in fact, we felt that starting dialysis may in fact worsen her cognition, her functional status, and her quality of life. So when a patient doesn't understand what's happening, dialysis can be quite distressing. And we've had many patients with dementia or delirium on the ward and even in the outpatient dialysis unit pull out their dialysis line multiple times. And even back in 2014, she hated dialysis, and I don't know if she truly remembered that. The second issue was pain control. So as you know, pain control can be tricky in chronic kidney disease, since many medications are renally cleared, and because we generally don't use NSAIDs. So we thought that something stronger like Dilaudid may worsen her cognition and function. At the same time, we didn't want to stop her Tylenol 3 because pain can exacerbate cognitive impairment. So we didn't make any changes to her Tylenol 3, but we did encourage her to use Voltaren gel for her large joints, which is largely where her pain was. and we made a referral to rheumatology for consideration of steroid injections for her knees. And then finally, we had to assess if she had capacity for medical decision-making. With her degree of cognitive impairment and inability to appreciate her illness, we told her husband that she did not have capacity and that moving forward, he, as her substitute decision maker, should be making decisions for her in her best interests. So even though her husband had suspected something was wrong, having the diagnosis seemed to help him. And I followed this patient's chart to see if our assessment had made a difference. And I saw that moving forward, the husband and his daughter, and this patient's daughter, made the medical decisions. And in the end, they decided to pursue conservative renal care and focus more on medical management and symptom management. This patient actually passed away later that year, which was not surprising. This was a really interesting study that looked at or compared conservative renal care in elderly patients to dialysis. And what they looked at was hospital-free days and days survived. And what they saw was that in the conservative renal care group, survival was certainly shorter by about 15 to 18 months. But the time gained for dialysis patients was not hospital-free days. So most of that extra time was spent in hospital doing outpatient dialysis or being admitted to hospital. So this is really something important to consider in our very elderly, frail patients. So there are many benefits of collaboration between subspecialties. So the first is that Dr. Sidhu and I have many in-person discussions and debates about age-related issues versus nephrology. And we think this is similar to what happens in tumor board conferences. Also, it's helpful for both trainees to have two physicians from both subspecialties present in the clinic. So for our nephrology fellows that rotate through, it's helpful to have Dr. Sidhu's expertise in geriatric medicine. For geriatric medicine trainees that rotate through, it's helpful to have me with my knowledge of nephrology and kidney-related issues. We have many discussions regarding polypharmacy. And we also try to understand and explain the diagnosis and treatment in the context of the patient's kidney disease. So one colleague wrote back, great consult, a comprehensive geriatrics assessment that includes all of the nephrology and dialysis issues. This has helped a lot. And finally, the geriatric experience and knowledge gained in this clinic translates into our general nephrology clinic and our dialysis care as well. So what we learned doesn't stay in this clinic, it can be applied everywhere. So next, I'd like to talk a little bit about our fellowship program. So the current landscape of fellowship training in nephrology is that prior to our fellowship, the only other fellowship was at the University of Toronto, and this was offered through UHN. And this was a more traditional fellowship where the fellow spent time with Dr. Meera Joseph, learning about modality discussions, goals of care and advanced care planning, dialysis of rehab, and an approach to falls. So the fellows don't rotate through different blocks or rotations, they stay within nephrology. The other geriatric nephrology programs that I could find in North America are at Harvard University and Duke University, but there isn't a lot of information on how their fellowship programs are structured. So Dr. Ganji and Dr. Sidhu developed this one-year geriatric nephrology curriculum. So this included 2 blocks of geriatric medicine clinic, a block of geriatric consult service, inpatient palliative care, home palliative care, geriatric psychiatry, geriatric med risk, the longitudinal geriatric nephrology clinic experience, research, and because I was a clinical scholar, I also had to do 8 weeks of nephrology service. It's not just the knowledge that I gained by doing this fellowship. My network of colleagues grew to include so many wonderful people from all of these different divisions and departments who I may not have otherwise had a chance to learn from or meet had I not left my own division. So I'm so grateful that all these wonderful people will be lifelong colleagues. So I was presenting academic half day to the geriatric medicine fellows this Monday, and one fellow asked, how has this changed your practice? So the first thing I'd say is it's really increased my comfort in incorporating geriatric medicine into my own nephrology practice. So for example, whenever I'm prescribing a new medication, I always think about how it might impact their falls risk, their cognition, etc., and I try to weigh the risks and the benefits. Secondly, it's increased my comfort in providing a palliative approach to care. So I certainly don't have the skills to practice as a palliative care physician, but it's certainly increased my willingness and desire to try and do more and continue to learn more. It's also increased my comfort in providing care in the home. So that rotation with Dr. Winemaker and Dr. Gallagher with the palliative care outreach team was truly an eye-opener and really made me see the value of doing home visits to those patients, especially nearing the end of life. So I have a few conservative renal care patients in my own practice who are not able to leave their homes. And for them, I provide home visits, which is wonderful for me and they are very appreciative of as well. And finally, I'm more familiar with the resources available for older patients. So it's not uncommon for me to make referrals to programs such as the Alzheimer's Society or the Stay Well program here at St. Joe's, even outside of my geriatric nephrology clinic. And what does the future hold for geriatric nephrology at McMaster? So we would hope to expand our geriatric nephrology clinic to include other referral sources outside of St. Joe's. So Dr. Sidhu is currently on maternity leave, but hopefully when she returns, we can expand our clinic further. We currently have 2 fellows who are in the process of applying for a geriatric nephrology fellowship in 2023 and 2024. So it's very exciting to see that this program has already gained some attention, and hopefully we'll be able to train many more fellows over the years to come. I'm trying to work with the Department of Family Medicine to develop a 1-year palliative care fellowship. What I was told is that the hope is to submit this fellowship by the end of the year, so it should be available next year. And this is designed for learners of all backgrounds, including learners with Royal College subspecialty backgrounds as well, such as cardiology fellows or cardiologists. And finally, I'm trying to participate in some cross-disciplinary research projects. Also, Dr. Lonnie Pine and I are starting a conservative renal care clinic at St. Joe's this week. So this is going to be a branch of our multi-care kidney clinic for patients with end-stage kidney disease who are choosing conservative renal care as their preferred modality. So when we did an audit a few months ago of the 766 patients in our multi-care kidney clinic, 87 or 11.4% wish to pursue conservative renal care, and 75% of those patients were over the age of 80. So they truly require a palliative approach to care, and need us to pay attention to some of those geriatric syndromes they may be developing. So our reasons for referral are going to be goals of care and advanced care planning, symptom management, end-of-life care, and education regarding conservative renal care for those patients who are undecided. So there are many benefits to working together, and together we can achieve so much. But next, I'd like to walk you through how we can equip our own learners with the skill sets they need to provide specialty care to an aging population. So this is the internal medicine curriculum at McMaster. And as you can see, or as you may know, geriatric medicine and palliative care are not mandatory rotations. And this is true for, I think, almost all internal medicine programs across the country. And this is surprising to me because no matter what specialty we end up in, we're all going to be taking care of aging patients and more aging patients as we progress in our career. And we all take care of patients at the end of life. So when I started my geriatric nephrology fellowship, one of my colleagues asked, isn't all of nephrology geriatric nephrology? And it's true that we see many, many older patients, both in internal medicine and nephrology, but that doesn't necessarily equip us with the skills needed to provide good geriatric care. So the first thing I would do is encourage your trainees to pursue electives in geriatric medicine and palliative medicine. A couple of years ago, Dr. Ganji made palliative care a mandatory rotation for PGY4 nephrology fellows, which I think was an excellent idea. and definitely a step in the right direction. The second thing we need to do is facilitate ways for our fellows and residents to learn an approach to symptom management and difficult conversation. So this was a study where they surveyed nephrology fellows and tried to assess their thoughts on teaching versus preparedness on 3 nephrology topics. So when it came to hemodialysis, nephrology fellows felt that they received a lot of teaching and they were very prepared. When it came to distal RTA, which is a little trickier, a little more uncommon, they received teaching and they still felt quite prepared. But when it came to end of life care, they did not receive very much teaching and they were left feeling unprepared. So this study was done in 2003. I would hope that things have changed over the 10 years since that time. So what are ways in which we can incorporate learning about symptom management? A few years ago, Dr. Ganji again introduced the LEAP renal course into the nephrology curriculum. So this was a full 2-day course where we learned about a palliative approach to patients with chronic kidney disease, including symptom management and difficult conversations. So this is offered through Pallium Canada, and it can either be undertaken as a longitudinal course or over the 2 days like we had arranged. So if this is something that you think would be applicable to your fellowship program, it is something that is definitely worthwhile considering. Another resource to point your learners towards is the Canadian Virtual Hospice. So this is a website that has many resources, courses, and discussions about palliative medicine. So for example, when I wanted to learn how to prescribe methadone, I went to the Canadian Virtual Hospice and there was a course on there. And then finally, there are many excellent podcasts out there. And the one that I want to highlight is one that's done by our own colleagues here at McMaster. So Dr. Samantha Winemaker and Dr. Sian Xiao have a podcast titled The Waiting Room Revolution. And it's a podcast to unlock the keys to a better illness experience. And it's targeted towards caregivers and family and patients. But listening to it, it's an excellent podcast for us healthcare providers as well. And then finally, I would like to encourage collaboration between subspecialties and departments. I was listening to Dr. Soy's grand rounds last week, and he was talking about how interdisciplinary collaboration is needed in the management of non-alcoholic fatty liver disease. And the same goes for care of our elderly patients. I really do think that collaboration is the way forward. So during my fellowship, I was able to work with a geriatric medicine fellow, Dr. Dana Trafford, to look at falls reduction initiatives on the nephrology ward. And because of the connections I made with geriatric psychiatry, I was invited to write a few textbook chapters for a textbook on psychonephrology. I was reading the McMaster newsletter this week, and I saw that the McMaster Institute for Research in Aging awarded nearly $250,000 in funding for interdisciplinary research on physical and social mobility in aging. So this again highlights that importance of collaboration and interdisciplinary care in providing care for our aging population. So in conclusion, all of us will see an increasing number of elderly patients as the Canadian demographics continue to shift. We're going to be seeing patients with larger and larger problem lists, with polypharmacy, and with an increased prevalence of geriatric syndromes. And for this, we really need to develop the skills to incorporate geriatric medicine and palliative medicine into our clinic practice. And there is a need to further develop collaborative care models. Thank you so much for listening, and I'd be happy to answer any questions.
Wonderful. Thank you, Dr. Joseph, for a talk that has been very clear and interesting, and demonstrating some excellent work that you have been leading with colleagues, and particularly highlighting this multidisciplinary and interdisciplinary approach to complex issues and looking at things in a new way. As we wait for some questions to pop into the Q&A, and I'll encourage everyone, if you do have any questions, you can just enter them into the Q&A box there for Dr. Joseph. I'm just wondering, if you were to make a prediction recognizing that you have this area of interest and specialty. What do you think things will look like 5 years, 10 years down the line in caring for geriatric nephrology patients? Do you see there being a big sea change in the approach and the nuance with which those discussions are happening across the board?
I would hope so. So even in my couple of years, I'm seeing more and more of an interest in geriatric nephrology within Canada. So one of the patients applying is from McGill, and McGill, you may or may not know, already has a geriatric cardiology fellowship program. So he's hoping to bring back geriatric nephrology to McGill. There is also a colleague of mine who is a nephrology graduate at UBC. And even though UBC doesn't have a geriatric nephrology fellowship program, he kind of designed his own fellowship in his clinical scholar year and did rotations with different geriatricians and palliative care physicians in the hopes to introduce geriatric medicine out there. Edmonton also has a very strong presence in palliative care and geriatric approach to care in their patients through the work that Sarah Davison has done. So I think it's, gaining more traction. We're starting to recognize that this is an important area. And hopefully with more people undertaking training and more fellowship programs and clinics being developed, we'll have more learners pass through or more fellows pass through these clinics. And even if they don't pursue fellowships in geriatric nephrology, they don't have to, they can still do transplant, GN, genetics, whatever, just having this experience throughout their fellowship training. My hope is that it will change their approach to providing care for elderly patients. I also provide academic half day to both geriatric medicine fellows and our nephrology fellows. So these are some of the things that we touch base upon. So small steps.
Excellent. And what do you think kind of societally, I wonder, just beyond even, you've highlighted the growing interest within the medical community and recognition of this niche. I guess with the families that you speak with, are they, what's their reception to this approach that's tailored to a geriatric population? Is this resonate with them right out of the gate, or does it require some framing? So I guess my question's twofold: the individual families, and then just messaging as a society about our approach to end-stage renal disease in the elderly.
So the families, so you're asking about the families that come to our clinic?
Yeah.
Yeah, so they're actually very appreciative of the appointments. The families who maybe don't understand it are the no-shows. So they don't even come to the clinic at all, but most of the referrals that we receive, the patient will come with a caregiver because we ask for a caregiver to come with them. And I had one colleague tell me that the patient and family told him that this was the most useful nephrology appointment that they'd ever had. So we spend a lot of time with our patients, getting to know them, getting to understand both the patient and the family, and we're really trying to help both the patient and the family. So I haven't really had anyone leave the clinic saying that they never want to return, except for when we have to report them to the Ministry of Transportation, because that never goes over well. But for the most part, everyone seems to be very appreciative, and they come for their follow-ups, which I think is another good sign. As a society, sorry, can you repeat that second part?
I'm just wondering, our approach to maybe complex medical problems in general in the later stages of life. Just whether you think that there's any role for education beyond the individual patient level.
Very good question. Not one I've thought much about. So I think this is really what Dr. Winemaker and Dr. Ciencio are trying to accomplish with their podcast. So they're really trying to disseminate information to a much larger population because their podcast is targeted towards a broad group of patients and also caregivers. So I do think that campaigns like that, education strategies like that are important so that families and patients are equipped with the knowledge they need to approach aging and end of life, and they know what questions to ask their physicians when they come to their visit.
Great, thanks so much. All right, there's one question in the Q&A, and then I'll hand it over to Dr. Matthew from Claire Lee. What is the average wait time for new referrals to your geriatric nephrology clinic?
So it's much shorter than a referral to a geriatric medicine clinic, which is one of the other advantages. So our wait time right now is about 2 to 3 months. Whereas if you're waiting for a geriatrician to see you, it's much longer than that. I think it's around 6 months or longer. So right now I'm booking into February.
Great, thank you. Okay, Dr. Matthew.
Hi. So, well, first, I just wanted to make a comment, having been someone who's referred a few patients to Dr. Joseph and Dr. Sidhu. I just wanted to say really crucially important. There isn't enough time in our 15-minute follow-up appointments to address all of these complicated issues, address the family issues, and come up with a very comprehensive plan. So I think it's a really important missing piece in our best care for these patients. And the second thing I wanted to ask, so, you spoke so nicely about the importance of cross-disciplinary work and the educational opportunities, and I'm sure that also provides a great foundation for research and quality improvement initiatives. You already mentioned your Falls initiative that you undertook when you're still in training. So maybe you could just share with us some of the research or quality improvement initiatives that you've been discussing in your work here.
Yeah, so I'm actually meeting with Dr. Alex Papiano next week. GERAS, so our geriatric research group, has developed a frailty app. And I'm meeting with her and her research colleagues to see how we can introduce this frailty app into our nephrology clinics to measure frailty in our patients and see how that might impact outcomes, whether it's transplant or their outcomes on dialysis. So I'm really excited to learn more about that app and collaborate there. I'm also involved in another research study that some of you on this call may be on. So this is a collaborative research project funded by CAHR, where we're looking at the involvement of subspecialists, family medicine, and palliative care in the last 2 years of a patient's life as they approach living with a chronic disease. So we have collaborators from respirology here and in Ottawa, and nephrology in our working group, but I believe they're also working with neurologists as well. So this project is pretty early in its early stages, but I'm very excited to see what the results are going to show.
That's great. I have another question. So you mentioned in one of the cases that you presented about a patient with 10 medications, and I was thinking, oh, most of my patients are on 10 medications even when they're not 80 years old. So what are some of the more common polypharmacy issues that you kind of run into? It must be a common issue that you address in the clinic. What are some common issues that you and maybe that could be a future quality improvement project?
I think the most common issue we run into in our patient population is pain medications, because there's a lot of cramping on dialysis. There's pain from sitting in the chair. So we tend to add one medication on top of the other. So they'll be on Percocet, they'll be on gabapentin, they'll be on pregabalin, they'll be on Dilaudid. And maybe one thing that we don't do as well is once we start a medication, do we do a good job of seeing if that medication worked? So when we add a medication and see that it hasn't worked, we have this tendency to just keep on adding instead of removing that patient or medication that perhaps did not work as well. So a lot of the deprescribing that we do is with pain medications. Dr. Sidhu also has an expertise in cannabis use in the elderly, and has found that cannabis has been very effective for reducing polypharmacy. So also in our clinic, we started a couple of patients on cannabis for pain control, and doing that, we've been able to cut back on some of their pain medications and sleeping medications.
That's great, thank you.
All right, thanks so much again for a fantastic presentation and a lot of very insightful responses to questions from both myself, Dr. Matthew, and from our audience. You continue to do the great work you're doing, and let those of us also, working here at St. Joe's, let us know how we can support the ongoing growth of that program. And to everyone who has joined us today, Much appreciation for your participation and attendance. Next week will be Chair's Medical Grand Rounds, so keep an eye out on your email for the notification about that. And then the week following that, we'll have Dr. Shui Ning presenting on a topic of platelet transfusions. And the week after that, November 17th, I believe, sorry, pardon me, yes, 17th, we'll have two international guest speakers who are Drs. Salim and Qureisha Abdul Karim, who are joining us from South Africa. And it will be a co-hosted event by our Department of Medicine, by HEI and the St. Joseph's Research Institute. So that should be exciting. Stay tuned. Have an excellent day and a fabulous week, everyone. And we'll see you again next week. Take care.
Thanks, Dr. Hotzek.